So I guess we should go ahead and get started. I'd like to welcome everyone and thank you for coming today to this panel of clinicians who work with or study HIV/AIDS. This panel and event and the food is supported by funding from the Center for Humanities and the Public Sphere. I would like to remind you to sign in. There's a sign-in sheet kind of up there to the right, and that helps us to justify the food. We would also encourage you to take a little flyer that talks about upcoming events in the series. This is part of a series of events associated with our hosting of an exhibit from the National Library of Medicine called Surviving and Thriving. So it's a series of events that are exploring HIV/AIDS in the world, more specifically in the United States. And then we also would encourage you to fill in one of the blue sheets, which is a survey/evaluation form. So for today, we have three clinicians who work on infectious diseases and often HIV more specifically, and they are from, I guess it would be your left to right, Dr. Gary Wang, who's Associate Professor of Medicine, received his MD, PhD from Temple University, and did his residency at Yale and New Haven, Connecticut, some undergraduate at Cornell. In the center is Dr. Robert Lawrence, Clinical Professor of Pediatrics in the College of Medicine. And are you still Division Chief of Pediatric Infectious Disease? He did his undergraduate at University of Rochester, MD at Cornell University, and a residency in Montefiore. Emily Huesgen is PharmD, Clinical Assistant Professor in the College of Pharmacy in the Department of Pharmacotherapy and Translational Research. She did her undergraduate at Indiana University and her Doctor of Pharmacy at Purdue. She has a Master of Public Health from UF. No. Okay, she's enrolled in a Master of Public Health program at UF. So I have given, obviously, the very briefest of background information, but I have a couple of questions that I can ask, but what we would really encourage everyone to do is to have your own questions for the panelists, but we'll just ask them to get started, and then hopefully everyone can contribute to the conversation. So essentially, kind of going beyond your titles, I'd like you to introduce yourself, kind of who you are, what is your specialty practice, how long have you been in practice, and what is the patient population with which you work primarily? And I think you need to turn on the mic. Okay, great.
I'm Gary Wang. I'm faculty here. I've been.
It's green.
Does it sound like it's on?
Yep, it's on.
It's on. Okay. So I finished my training in 2009. Actually, I finished my clinical training in 2006, but I stayed on to do a postdoctoral fellowship in really part of HIV life cycle in basic research. And I came here in 2009 and faculty here. And in 2014, I moved over to the VA. So I'm primarily at the VA for clinical activities. Most of my clinical activities are all outpatient HIV, and more recently evolved into HSC, co-infection. I still run a research lab here at UF, focusing on HIV resistance and a bunch of other infectious disease sort of activities.
So I'm Rob Lawrence, a pediatrician, and I guess I finished my clinical training in 1983, which was around the time that HIV was first diagnosed. I was at Montefiore in north central Bronx, where Ari Rubenstein, immunology pediatrician, described the first 4 cases of HIV in children, and 2 of those cases were cases that we took care of when I was chief resident. So then I stayed at NYU for 18 years, where we took care of over 2,000 kids with predominantly perinatally acquired HIV, and then in 2001 came to the University of Florida and have been here. Coming at NYU, we were part of the Pediatric AIDS Clinical Trial Group, so clinical research in children and how to treat them and how to prevent HIV in children. And then here we continued some of that work, and I continued to take care of children in actually 28 counties in Florida, from here to Pensacola. And so I traveled to do clinics in those different areas because it's easier for me to travel than it is for families and children to travel all the way here. So that's really my clinical care is really up to whatever, 21, 22, depends on how one defines that transition into adulthood and transition into adult care.
Hello, can you guys hear me? My name is Huesgen. I'm a clinical pharmacist. I'm a relatively new clinician. I started my pharmacy residency in 2010 at the University of Illinois at Chicago. I did a 2-year HIV specialty residency, so we treated both HIV patients on the inpatient side and then also on the outpatient side at UIC, and then we would also do rotations over at the Cook County Hospital, and then Core Center, which has like over 6,000 HIV patients, one of the largest centers in kind of north central United States. And after leaving in 2012, I got a position here as an assistant professor here at the College of Pharmacy. I spend about 50% of my time teaching students at the HIV pharmacy elective for any pharmacy students or potential students that are interested. That's in the spring. And I also teach some other core courses and spend the other 50% of my time traveling with the infectious diseases clinician to HIV clinics kind of in north central Florida and some kind of in rural areas, and work kind of one-on-one with the physician and also the nurse practitioner to kind of tailor therapy, simplify HIV regimens. I work with them to kind of prevent and assess potential drug interactions and side effects, and do drug resistance interpretation. So relatively new, but it's very rewarding working with these patients and making a difference. A lot of patients are stigmatized, ostracized. There's still the rumor out there that this is a death sentence, so it feels really good when you can kind of empower them and kind of help them on the road back to success to turn their lives around.
Okay, so I'll go ahead and jump in with a second question, which is really asking you to talk about, I guess in particular, changes you've seen in treatment available to people who are HIV positive, or else if you're relatively new and haven't necessarily seen changes, maybe even just kind of describe that treatment regimen.
So I'll say one thing, that is just that in general for pediatrics, children and the availability of drugs for children tends to lag behind for adults, and part of that's the formulations that you can provide in terms of liquids that are even semi-palatable, but also just making sure that you have the good data on pharmacokinetics and potential side effects that could be slightly different or could be accentuated in kids. The one thing that I would say, and I'm sure both of the other panelists will recognize this, is early on, when we then started to have a panel of medications that you could use, and they were in different classes, I would say to people, well, yeah, it's a little like a Chinese menu. You pick one from column A and one from column B and from column C. And I was being facetious. But the reality was that you needed to combine medications that had different mechanisms of action, and that was part of what you utilized to prevent resistance. And clearly, the general statement would be that's absolutely no longer true. It's very clear which individual medications in different classes are superior to others, which combinations are in fact better, and that it actually is very tailored and specific, and so it is very easy, not easy, it is very possible to tailor regimens for individual patients based on who they are overall. So that's just my general opinion. You guys do it for adults all the time.
Right. I guess I sort of caught the tail end of the complex regimen in the early 2000s when I was doing my medicine residency. So I still remember times where, of course, at the time I didn't really know the toxicity of the drugs, being a general internist at the time. But I did see some of the more complex regimens that are really difficult now in retrospect. We never use them these days unless we have to. But I really saw the evolution of the newer regimens over the last 10 years, where the focus has really not been on whether or not we can suppress the virus. It's whether or not we can find regimens that are really easy for patients to take, to be able to adhere to those regimens for a long period of time with very low toxicity. So most of the patients that I'm seeing in the clinic now are sort of try to finesse their regimen to a point where it's so easy compared to the rest of the complex regimen, complex medications that they have for other diseases. So if you look at their polypharmacy, most of the medicines are actually not HIV medicine. They're cardiovascular, diabetes medicine, and so this is unfortunately one of those medications that you still have to take lifelong. And the questions patients are having these days is, when can I stop, or is it ever going to be a cure? Not whether they're going to have issues related to HIV. For those patients who are, who understand the infection disease for a long time, that they know they can do this. It's more about the next frontier, the cure, HIV cure, which unfortunately is not really in sight at the moment.
I would agree with what the other panel members have said. HIV used to be a death sentence. Over time, we've gone from having to take double-digit numbers of pills a day, 10, 12, 14, down to, we have like 5 single-tablet regimens, and more and more coming out in the market that are just a slight improvement from the previous. So now, as they said, it's no longer just about finding a potent regimen to suppress the virus, but about finding one that kind of works with your lifestyle. Do you prefer to take it with or without food? Does the size of the pill matter? Are you more concerned with side effects? Things like that, potential drug interactions, avoiding them. So it's really great that we can tailor them with their various options. And yeah, assuming patients can take their medicines and swallow them on a day-to-day basis, they can live just as long as you or I are HIV negative. So it's fantastic.
So mainly because I'm, quote, older. So I was taking care of kids with HIV when, first of all, we finally had a test where we could actually test for the virus, and that was in 1985, and then subsequently in 86/87, we had the use of zidovudine or AZT, and just historically, that as a single medication used in patients who were already very, very sick. This was to talk about side effects and talk about problems in people's preferences or their response to therapy. First of all, it was a single medication, so they didn't necessarily get good viral load suppression at all. Secondarily, because they were sick with many other things and many other issues, they often interpreted that the problems they were having were related to the medication. And then subsequently, the fact was that the medication would fail because it was just a single agent. And so, as an example, AZT or zidovudine had a very, very bad reputation, and there was a lot of turmoil and disruption because of that. You all had the exhibit with Keith Haring, and he was in New York at that time, and so ACT UP was the political action group that worked to try to get the government to support additional research and additional studies. But if you imagine now what we see today in terms of people speaking out and a little bit of the back and forth that we're seeing every single day in the news, that absolutely was what was happening in New York, but it was happening about HIV and the medications and how that would work. And just to carry it one step further, for kids, the issue is we have an opportunity to actually prevent HIV. And so that's, the majority of kids would get it perinatally, meaning at or around the time when they were actually born and delivered. And 1/3 of transmission would occur or could occur during pregnancy in the previous 8 to 9 months. But we learned that we could actually prevent it. And that was by using simply one drug, AZT. Mother could get AZT. If we gave AZT IV during delivery, so at the time that the mother came in to deliver, and if we gave it to the baby for 6 weeks, we could decrease the risk by 2/3. And that was with a single drug, which, again, a drug that was not well liked or didn't have a good reputation or a good apparent track record. But very clearly with that regimen, that clearly made a significant difference. And that occurred in 1993 to 96. And if you were to look in Florida, you would see in 1985 and 1986, those were the 2 years that they had the highest number of children who were infected with HIV in each of those years. And the numbers were about 140 to 160 children a year in those 2 years. And then after that, with the onset of having other medications and then getting more and more medications and having these complicated regimens, we actually saw that declined significantly. So, some of that, exactly what you guys said, this real evolution, I said to you already, PEDS was always a little bit behind because of the formulations, because of the research that was done in adults first before research was done in kids. So you could really see this difference, and you could see what was happening for patients in terms of those complicated regimens and the potential side effects of those, and the difficulty of combining them with other medications.
I guess I did send you a couple of questions, but as I'm listening to you talk, one question that comes to mind is just what led to your interest in infectious disease, but in particular, maybe focusing on HIV? How did you become interested in that?
Well, during undergrad, I majored in microbiology, so I always had an interest in kind of bugs and drugs. But for me personally, it was my 2 months overseas doing an international pharmacy rotation in Kenya. I think that kind of solidified my desire to work with infectious disease patients, and particularly with HIV.
Say, I think it was I was a bit undifferentiated when I was going through medical school and medicine residency. I thought microbiology and viruses are always interesting, and so and so I chose a specialty. Focusing on HIV was I don't think that was my initial thought, although I was very interested in viral diseases, and just I think thinking back toward the end of my infectious disease fellowship, I did a sort of international rotation in Botswana, where I was able to see sort of early phases of HIV epidemic. This was sort of in the early 2000, mid 2000 or so, 2004 or 2005, and I was able to see the disparity of the care that was provided here in the U.S. or Western countries versus Africa. And so at that point, I decided I want to focus on HIV clinical care and also focus on research in HIV.
You heard a little bit of where I came from in terms of as a resident. I went on to do an ID fellowship at NYU, and I actually went there with interest in 2 other infectious diseases, tuberculosis and chickenpox or varicella. But when I went there and the numbers of children that were increasing with HIV, in fact, in Bellevue Hospital in the late 80s and through the 90s, between 1% and 2% of every mothers who delivered at Bellevue Hospital, they were HIV positive. And that was a huge number compared to what one would see in other places. But would see it also in Chicago, at, say, Cook County as an example, that would have been potentially true there as well. It's just one of the things that we actually track. And so having that opportunity to take care of patients at the same time as we were trying to do research in terms of what are the drugs that work and how do we really prevent this for kids, that was definitely it. I did have other opportunities with families and patients, which I think is part of why I sort of stay involved with taking care of kids, and that is I got the opportunity to be, quote, medical director for a camp of families with HIV. And so this was back when people wouldn't even, the first year that families came to camp, we got the use of a camp, and they, no one was allowed to say where the camp was. No one was allowed to say that they went there, that they went for the week. No one was allowed to say, because other people would use the camp for the rest of the summer. So no one was allowed to say that anybody with HIV went to this camp. That was the first year we did this. Let me tell you, the families loved camp. It was unbelievable. It was families with only usually one or maybe two people who were infected, but the whole family was affected. And so we had that camp for 11 or 12 years in a row. And let me tell you, being able to talk with these families outside of the clinic and outside of what was day-to-day doctor discussion and things, and really hearing what they were struggling with and hearing how they took medications. I mean, oh my goodness, really? That's what you do? No, is that what your doctor said? Really? Not, you know, and it obviously wasn't what their doctor had said, told them to do. But just really hearing different stories and stuff was, I think, probably the reason why I'm still in it.
Does anybody in the audience have questions? Yes.
I'm curious, I'm Isabella from Ghana, of your prevention of mother-to-child transmission. And how do you go about it, the strategies? If you can mention a few areas you began there.
So in the United States, the strategy is pretty standardized, if you will, and there are very specific guidelines for it. And that is simply identifying women who are positive, ideally before they become pregnant, and certainly, Dr. Huesgen and Jennifer Brier, when they go places, they really talk to mothers, or I shouldn't say mothers, women, potentially mothers, about what are their plans about having children and stuff like that, so they can actually anticipate that and really approach that on the front end before they actually get pregnant. But utilizing antiretroviral medications during pregnancy for the mother, a regimen that actually is appropriate for the mother, the best regimen based on all of their illness, whatever other conditions they have, and suppressing the viral load optimally, meaning ideally to less than 20, and then making the decision at or soon prior to delivery. Should they get a cesarean section? Should they get IV AZT during delivery? And then, without question, the infant should be treated for some period of time afterwards. If you look in Europe, they give AZT for only 4 weeks postnatally. We still give it for 6 weeks here. Based on our experience and not others' experiences. And so it's pretty standard here, and that includes 2 other things. One is proscribing breastfeeding, so we do not recommend breastfeeding here, and proscribing pre-mastication of food. So what does that mean? Infants and children, as they transition from predominantly milk feeding, will eat soft foods, and if you don't have baby foods on, in jars on shelves at the store, then you would pre-chew formed food to give to infants, or you would make very, very soft food. The obvious things are cereals and mashed fruits and vegetables are some of the first things that infants take. But mothers also would pre-chew that food and give it to their infants. And so that's another way for transmission, which has occurred in Florida. There are documented cases of that. So that would be pretty standard for here in the United States. If you look at Florida in the last 2 years and look at the number of infants who were infected, and that would be 8 in 1 year and 10 in the next, as compared to 140 or 160, 15 or 20 years ago. The women who do transmit to their children, they often have drug use in their medical history, they often have mental illness, or they, in some other way, are marginalized so that they don't think they can come to clinic, they don't think they can get it paid for, because every mother in Florida can get their pregnancy care cared for and paid for. Doesn't matter where, who or where they are from, including people internationally can come here. And those are the issues that are much more pertinent to, does this child get infected or not, is based on those very important social issues for the mom. Did I answer your question?
So the AZT IV, you currently use it when you have to.
So the guidelines, what the guidelines say is within the short period of time before delivery, if that mother has a well-controlled viral load and ideally their CD4 counts have recovered during pregnancy, and that viral load is under 1,000, the guidelines say you don't have to use it. I totally disagree with that. And the reason I disagree with that is because the original studies used IV AZT during pregnancy, and I guarantee you that when people go to assess these women at the time of delivery, they have no idea what the viral load is in the last 2 weeks or the last 4 weeks. They haven't done a viral load in 2 months. And that's ridiculous, particularly when we see how many people have trouble taking the medication all the time, how in pregnancy you can be sick and not feel good and not be able to take your medication. So to assume that I have a test from 2 months before and it's still the same now without asking all the other questions, without fully understanding, you're missing an opportunity to protect this child. I think it's ridiculous to have that recommendation. Or I think that we, physicians and medical community, don't pay enough attention to the full recommendation versus just, oh, you don't have to give it. Does that make sense? So in this country, it still would be very appropriate to do it. In this country, in any country, it would be, when was your last dose of medication? Have you missed any doses? Oh, you haven't taken it for 30 hours? It's time to take the medication now, and to take it before you actually deliver. And that would be an appropriate intervention, even if you didn't get IV AZT. It would still be an appropriate thing to get it in the appropriate timing that you should have gotten it anyway.
Are there any negative implications of putting an infant on IV AZT? Is there any long-term, or is it really considered safe?
So the Pediatric AIDS Clinical Trial Group has followed infants, and they actually followed a cohort of infants who were born to mothers who were HIV positive, but the infant didn't receive AZT. That could have been an older sibling who never got AZT, and they looked at the siblings who got AZT, and they followed over 1,200 infants. About half never got AZT, and half got AZT, and they could not identify long-term differences in kidney function, liver function, bone metabolism, cognitive development in those 2 different groups of infants. The one side effect that we do know that commonly occurs is infants are usually mildly anemic if they have taken the AZT. Within 2 to 4 weeks of coming off of it, at 6 to 10 weeks of age, they are no longer anemic. They rapidly recover.
Does the state provide like a formula feed for the infants?
Do we provide it?
Yes.
Yes, WIC provides it. It's available for any mom here to get it. And even if you, for some reason, didn't sign up for WIC, there are a variety of other resources where you could actually get the formula.
I was going to ask a question too, and this is for everyone, I suppose, but is there like a common, because I know sometimes, at least for maybe tuberculosis, there could be like drug susceptibility testing. I didn't know if, like, is it common to test for different serotypes of HIV and kind of tailor drug treatment towards that? Or is there just kind of a catch-all treatment that is usually administered?
Yeah, so the standard of care in adults is you do what's called a genotype. You look for drug-resistant mutations in the virus prior to initiating therapy. And it really depends on where you are in the country. I think, in my experience here, we have not seen a whole lot of drug resistance, at least in North Florida. But certainly in the more metropolitan area, you'll see more, mostly because of transmitted drug resistance. So people are infected with someone who has failed regimen at some point in their life, and they, or they're not taking their medications consistently, and so they actually have virus in their blood that's drug resistant. And so, because resistance testing is inexpensive relative to the cost of the drugs, that is currently the U.S. Currently guideline for that. We also do drug resistance testing in patients who are family regimens. And so that is fairly typical. We expect to select for drug resistant mutations in most regimens. Although there are some regimens, it's hard to select for resistant mutations.
Do all your patients get a genotype before they start therapy?
All of our patients get baseline genotype testing and entry into care.
And all your patients Ryan White funded?
No, but quite a high percentage of our patients are funded through the Ryan White program. I mean, there might be an occasional few that slip through, but yeah, I would say we do a pretty good job just with kind of standard lab orders to get baseline testing and entry into care.
And would you say that that's changed since you've been here?
I think so.
Maybe before you came, we didn't get genotypes so readily, and part of that was funding and stuff. And so people would get put on a regimen, and they would look to see what their response was, and then they would do it. And that was funding, and that's why I asked about Ryan White, because I know Dr. Huesgen does this all the time. This is her day-to-day stuff. She does this all the time, and looks for that genotype and checks it. But in the past, clearly that was an issue, and that's why it's now the standard of care, is that it really guides therapy. So, and there is more funding for that.
This is just follow up about the funding question. So we mentioned, of course, back in the day, AZT, there was lots of protests, lots of unrest about that because of the dosage and side effects and whatnot. But now it seems that the most recent protests regarding HIV and AIDS are about the cost of medication. Like you mentioned earlier on that it's no longer just pick one from column A, column B, column C. It's now like, no, we actually know which one's the best ones, and it seems like some of the best drugs are quite expensive, $3,000 a month type of expensive. Can you speak a little bit about pricing and Ryan White and the rising cost of medication, or if it's not rising, or how your patients handle that?
Great question. So the medications are very expensive, as she mentioned. For our patients with insurance, the medications get billed to their insurance company. Sometimes if the drug's not on the preferred formulary for the specific insurance, then we'll get a rejection back, requiring a prior authorization in order to get approval. And so that's something we kind of do behind the scenes. We'll complete that. We'll submit the necessary forms. And hopefully after that period, we can get coverage for the patient. Sometimes, very rarely will they not do it if, after we've completed the prior authorization. Some other things we can do in terms of cost, copay assistance cards by the manufacturers. So even if the patient does have insurance, say their copays are high, nobody wants to pay $30 a pop with 1 or 2 or 3 medications a month. So that's something that anybody that's around these guys can help them with. And just by going to the manufacturer's website, usually there's a place you can go to click and to download a copay assistance card or get the patient enrolled in it. And that's, another thing that can help them, help improve adherence. And then finally, and that's approved for anybody that's not like federally funded through. So that exclusions would be Medicaid members, Medicare, people with TRICARE insurance couldn't do the manufacturer copay assistance cards, but anyone else could. And then finally, for patients that don't have insurance, they can get enrolled into our Ryan White program. So Ryan White was a young hemophiliac child from Indiana, my home state. That's who the grant was named after. It's a federal grant. Depending on your location, the funding is different, and that's just based on population size. But these guys can get enrolled in our AIDS drug assistance programs, or ADAP, and they get funding for these medications, for HIV medications, for any type of prophylactic medications they need to prevent them from getting opportunistic infections because their immune system is too low. They can get those as well. And ADAP, they're here in Florida. They have a ADAP panel of members that kind of vote whether or not to put the drug on the formulary. And most of the drugs are on the formulary. So it takes a little bit of time following FDA approval, but they get on the formulary. So I would say insurance would be the biggest difficulty.
How do I?
Yeah.
So I have a skew view of the medication costs. I work at the VA. So the VA negotiates a national contract with different pharmaceutical companies, and so the drug costs are, I'm not sure what they are, but they are somewhat comparable. There's not a huge difference. Of course, the newer drugs tend to be slightly more expensive than the older drugs, but if you look at the monthly costs, they're not as big as I would expect. And all the veterans get, basically, if you're HIV positive, you are eligible to receive medications forever. And so there's no issue about private insurance. They're trying to build private insurance. They come to the VA, but that's not a deal breaker. They provide all the care related to HIV and a bunch of other things as well. So it's a skewed smaller population.
So it's my understanding that some drug regimens, being on a previous drug regimen, can actually make you more likely to fail some of the newer ones, like I guess so raltegravir or dolutegravir are a couple of the drugs I think where they're new and more expensive, but do you guys go to those as frontline medications more often now, rather than waiting for an individual to fail like a previous drug regimen?
Great question. So again, it's patient specific. Ideally, we try to give the patient something that involves minimal pills once a day that's easy to take with less side effects. The integrase inhibitors, as you mentioned, raltegravir, dolutegravir have minimal side effects. So yeah, ideally, if there are no contraindications, we'll go to those regimens. But we let if the patient's a candidate for multiple regimens, we'll kind of explain the pros and cons between a couple of them and let the patient pick. Kind of power them that way. In terms of if they're on, say, raltegravir beforehand and maybe want to switch over to one of the newer medications, they absolutely can do that. The only problem would be if they were poorly adherent to the regimen before. And when that happens, it's different than just never taking your medicine or completely stopping it for 6 months cold. For patients that just 50% of the time or so, take the medicine every other day, you still have the drug in your system, but you have such low concentrations that it's easy for the virus to replicate and to mutate. And so that's where you get into problems with drug resistance. And we can treat the virus. We can treat the virus. We can't quite cure it yet. So there are many medications available, but people get backed into a corner if they do have poor adherence and if they are taking their medication suboptimally. Does that answer the question?
Yeah.
Okay.
Question about transition of care. So you have these young people, and now they're having to learn all of this stuff that their parents used to make the decisions for them, and then also they're adolescents and they're getting into their sexual engagement stage. So how do you counsel these people and how do you help them transition to adult care?
So in pediatrics, we actually think about transition a lot because it's not just true for HIV, it's true for heart disease, lung disease that are more specific to pediatrics and are perhaps less characteristic of adult medicine. So we absolutely think about it. We actually have a program where we look at kids 13 to 15, 16 and 17, and then 18 to 21. And we have advisors, we have peer educators, so someone who had HIV who we hired specifically as a young person to talk with our patients and talk to them about, okay, what's happening with you, what's the rest of your life like, how are you transitioning in all aspects of your life, school, work, socially, cognitively, emotionally. Those are all things that will affect how people take their medication, how they interact with healthcare professionals, and how they actually advocate for themselves and really feel empowered to do this. And we actually give our adolescents little tests in terms of, oh, so what are your medications? Okay, which one is which? What do you do when the pharmacy says you have no refills? What do you do when you go to the lab and the lab says, no, you can't get your blood drawn? We give them scenarios and try to get them to problem solve around them. The other thing we do is we talk in general with our colleagues, so we don't send an adolescent patient to see an adult provider unless we've already talked to the adult provider and we've already tried to match them up in terms of, okay, what do I think? I think they're going to do this. As pediatricians, we tend to baby people. To be very honest, it's a problem. It's an issue that is really our problem, and so we try to not do that, but we do try to have them go see the adult provider and come back and see us, and have them go see them again and come back and see us. And all we're doing when they come back and see us is to say, well, what did you think? How did you like it? What did they do? Oh, they asked you hard questions, really? And you didn't know the answer? And we really try to connect them and make sure that they're getting it, that this person is good and why. And if they felt like they had tough questions asked by the adult providers, we ask them, really? We've never asked you that question here? With the idea that they really have to understand that, no, this is what you are, what you do need to do. And this is just like us, it's no different. We're gonna stop babying you. So we do actually do that. And Dr. Janelle, who works with Dr. Huesgen and stuff, we will often send her young women if we can do that. We have a young man who just went to her, actually, I don't think went to Zoe Mueller, who's another provider. And this young man came back and was like, wow, I really liked her. She was really smart. And we were all going, okay, I'm not saying anything. Yes, she is. She really is good. No, meaning she is, but not to quibble with them about it and stuff, right? So, yeah, support them and encourage them and cheer them on. And we do actually usually have a party. We have a cake, and we try to treat it like graduation. With the simple idea that they are graduating to take care of themselves and that it is something very positive. We're not abandoning them, which is often the feeling that they have is when you've taken care of them for whatever, 15, 18 years, they do still feel abandoned with just about anything that you try to do. But we do go to birthday cakes and parties and bowling parties and stuff like that. So.
Related to this idea of transition of care, I want to ask about the other end of it. I mean, we've just recently had like the first case of an HIV positive person getting Alzheimer's, and like now that HIV positive people are living longer, there's now a whole new set of issues that are happening. And so I kind of got maybe from just the treatment perspective, like how are we discovering, like, are there any horrible contraindications between like our, art therapy and our art regimens and these diseases that tend to hit the elderly. Thank you, I couldn't think of words. What complications is that bringing in?
Oh my goodness, that's a great question. To answer your question kind of broadly, yes, there are contraindications for drugs. So anybody that's interested in pharmacy, this is a great area for potential intervention. I think having kind of multiple team members on these treatment teams improves care, more eyes on the patient, patient's labs, drugs, et cetera, is going to, ultimately improve outcomes. So I guess, are you asking in terms of what type of secondary comorbidities the drugs can cause?
Like just as far as, or even if you're just trying to treat something like Alzheimer's, like do you have to be careful about what prescriptions, or if there's some sort of any other kind of diseases that that are red flags as far as like maybe we have to adjust the ART meds because now they have to take this new heart medication that they didn't have to take before, and ART meds are contraindicated.
Sure. Yeah, there are quite a few of them. I mean, for example, we now have over-the-counter corticosteroid nasal sprays, right? You can get over-the-counter. So those, even though they're localized, those interact with protease inhibitors, particularly ritonavir. We tell our pharmacy students that rifampin is one of the drugs to treat tuberculosis, is like the universal inducer of kind of interacting with medications and lowering their concentrations. It pretty much interacts with water and everything. The same is true for ritonavir, except it's pretty much the universal inhibitor, so it's going to raise drug concentration. So I think some, potential for pharmacy intervention with over-the-counter medications, such as these corticosteroid nasal sprays, and the same is true for inhalers, et cetera. Although they're localized, giving them with ritonavir increases the risk for drug interaction, which can lead to Cushing syndrome and cause all sorts of complications. So just catching little things like that. So we try to, at every visit, when we do a drug history, get all their medications, prescriptions, over-the-counter medications. And I think to answer your question, now that the patients are living more and just like anybody else, they're having, developing more comorbidities, they often see more specialists, whether it's a cardiologist, endocrinologist, so making sure to have a complete medication list and screening for drug interactions and then adjusting accordingly, absolutely.
So I do take care of a lot of adults, and a lot of them are getting older. You see them, some of the patients I've seen here for about 7 years, and so the average age in my panel had aged about 7 years. And I think thinking back, there's a lot of change in how you provide care in the last 10 years. Initially, I was providing care focusing on HIV-related issues, the opportunities, infections, and whatnot. Right now, most of my clinic time is spent on other things. It would be 2 minutes of reviewing your labs and your medication, and they're happy with it. Okay, what do we do with the next 28 minutes? And so we do have half an hour slots at the VA, so we do have a lot of time to talk about other things. So I almost become the primary care providers, even though we don't provide primary care. There's separate primary care at the VA. We take care of their blood pressures and other things. And so medication is becoming more complicated because of polypharmacy. A lot of times they're kidney disease creep up, and then you have to adjust their medications. And so a lot of issues with CNS disease we don't fully understand, right? So HIV can affect your brain function, and it's hard to tease out exactly what something is, what's happening with the patient is related to HIV, or is it related to something else that's much more common. And so you constantly ask those questions, and the pharmacokinetic questions is kind of really complex. Without a pharmacist, we would not be able to do this, actually. So I think we're providing care to patients as a whole rather than just focusing on the HIV issue. We still talk about the preventions and transmissions and other things, but a lot of times focusing on aging in HIV.
I think there's time for one more question. So, you said your hand went up first.
Do you have the insights used on vaccines for HIV? Is that something in the near future, or even possible with all the limitations in HIV? Or do you have any secret knowledge.
That's a great question. I don't, but I guess one more thing that we haven't mentioned is PrEP, or pre-exposure prophylaxis. So that is available, and I think some people aren't aware of that. So there is a medication, a combination tablet called Truvada that can be given to HIV negative patients in order to help prevent HIV acquisition. So sorry, a little off topic, but that was one other thing that I wanted to mention that is available. But I can't give you any insights on the vaccination.
So there continue to be attempts and failures in terms of vaccine use, and part of the problem is because of the fact that the virus does mutate, and trying to, that's one factor. The other factor is simply the protected environment that the virus is in inside the cell, and the changes that it does to the cell, and the fact that it can survive in, quote, long-lived cells in the body. Those are probably the issues that are really going to continue to make vaccine, which we usually do to produce an antibody against a particular infectious agent. Less commonly, we do it to produce cell-mediated immunity, which might be the more important factor for getting rid of virus inside of cells. So there are at least, there are probably another 3 or 4 mechanisms that are problematic for really creating a vaccine that will be effective. We'll keep reading about the next newest thing. Usually it's a good 10 plus years ahead of when they should be announcing it or putting it in the newspaper.
Right. Vaccines are effective if you can mount an immune response against all of the viruses that are that the patient is challenged with. Right. So the problem with the viruses is so heterogeneous with envelope sequences that are very different, and so you have to mount a broadly neutralizing antibody response in order to prevent disease. I think that's the major challenge to be able to do that. That's why we don't have a vaccine for the common cold. It mutates all the time. So, well, it also doesn't kill you, so we don't really spend the time to develop a vaccine to do that.
So I guess technically we should be finishing, but I just wanted to open the floor for you to say anything that you would like to say as a wrap-up, maybe something that hasn't been addressed, or just some final thought that you might have for each of you.
So one thing that I didn't say was, well, being at the VA, we take care of veterans in South Georgia and North Florida in general, so it's a very large geographic area. So we do see a large number of patients through telemedicine. So I see them through sort of Skype within the VA. And so we can provide those kind of care because patients travel 4 hours. And so I don't travel out to them, but they show up in the local clinic, and I see them for 15, 20 minutes, and they're happy. We rely on physical exams on their local providers. We can take care of HIV pretty much anywhere as long as you have a hookup of that.
We don't. Sorry. We don't do that yet in Florida, strictly in Florida. And part of the reason is because the state of Florida, who quote funds me to go take care of kids in other places, they won't let me do it in that format. And then otherwise, insurance still won't pay for it. So if you happen to have a patient who had insurance, you couldn't get reimbursed for it. So it's not that you can't do it. You can. The other issue for me is wanting at least 1 or 2 visits with the person in person before I do that. And more, I think, in general, either for the parent or when you're really talking about an adolescent, really needing to see them in person, just to have some initial connection with them. Then they'd be probably pretty happy to even do it on their phone. That wouldn't quite meet HIPAA.
I see potential for telemedicine with the prisoner population. We had a little bit of experience with that in Chicago. We took care of all of the prisoners throughout Illinois using a telemedicine program that involved an infectious diseases physician, a social worker to help kind of set up follow-up care outside of the prison system once they were to be released. And then there was a HIV pharmacist on board, and it was fascinating, the technology involved. The nurse at the local prison center had a specialized stethoscope, with a microphone on it, and so our physicians on site could actually hear the breath sounds, the heart sounds of the prisoners, and they had a high-tech camera if somebody had like a skin infection that they wanted to show us. So it's kind of going into it, you're like, well, it's not going to be as personalized. I don't know, this isn't going to be, as, you're not going to be able to develop that rapport with the patient. But, actually, I think the opposite was true. I was very impressed with the system. So it would be nice to be able to develop something like that with some of the prison population, just because they don't have a specialist on site. Not all of them have the opportunity for infectious diseases provider to visit. Some do, though.
I think that